Hi everyone, today we'll be talking about the diabetic diet, in particular the order of eating. A common question that I get is, does the order in which I eat food matter in terms of spiking my blood sugar? And to answer this question, we'll be looking at the systematic review from October of 2025. It sought to answer the question, does the order of macronutrient consumption truly matter? Postprandial hypoglycemia is strongly linked to diabetes complications. It is an independent risk factor for cardiovascular disease and the microvascular complications of diabetes. That is diabetic eye disease, kidney disease, and nerve disease. Meal composition is well studied. You may have heard about the diabetic plate method, which states that 50% of your plate should be high fiber, low starch vegetables, 25% should be lean meat products, and the remaining 25% should be complex carbohydrates. But meal sequence is a simple behavioral intervention that may improve glycemic control without changing total calories or foods. So let's look at some of the intervention characteristics that were included in the systematic review. Basically, they had a typical carbohydrate last strategy, meaning that patients ate fiber and vegetables first, then protein and fat second, and finally carbohydrates were eaten last. And this was compared with patients who ate carbohydrates first, or they had a normal mixed eating pattern without any rigid sequence. The results were that the carbohydrate last group significantly reduced postprandial glucose. The 1-hour glucose was decreased by about 42.7 milligrams per deciliter, and the 2-hour glucose was decreased by about 13 milligrams per deciliter. They also noted higher postprandial GLP-1 levels in the carbohydrate last strategy, suggesting enhanced incretin physiology. There was a small but statistically significant improvement in HbA1c levels. The proposed mechanism of action was 1. Slower gastric emptying. By eating protein, fat, and fiber before carbs, you slow down glucose absorption in the small intestine. Incretin enhancement. Earlier GLP-1 release led to increased insulin response and subsequently reduced postprandial glucose. Reduced glycemic load rate. Carbs were absorbed more gradually. And finally, behavioral simplicity. Unlike restrictive diets, there was no calorie counting, no food elimination from the diet, and so easier adherence potential for patients. Now, this is a low-cost behavioral strategy, meaning patients don't have to go out and purchase any new foods. They simply need to reorganize the way in which they eat food already. It is potentially useful as an adjunct to standard nutrition therapy. So as I mentioned before, patients would use the diabetic plate method and just ensure that they eat their carbohydrates last. This is particularly relevant for pre-diabetic patients or newly diagnosed diabetic patients. Also, patients struggling with dietary restriction. Now, there were some limitations with this systematic review. The studies included had fairly small sample sizes. These studies were of short duration with limited long-term metabolic data. The populations were typically either pre-diabetic or newly diagnosed diabetic, so the findings may not apply to advanced disease requiring insulin. And finally, there was some heterogeneity between the studies, i.e. they had different meal compositions or sequencing protocols. Now, just some key considerations, which are some points that I reiterate to patients. This is not a substitute for pharmacological therapy. Medications like metformin and Ozempic have a much greater potential to lower HbA1c. You still need to adhere to the diabetic plate method. You can't have a diet high in carbohydrates and simply eat carbohydrates last and expect to have good postprandial glucose levels. Most studies were conducted on pre-diabetic or newly diagnosed diabetic populations, meaning that if you have been diagnosed with diabetes for a prolonged period of time, or you have insulin requirements, this method may have a weakened or attenuated response. And finally, more long-term RCTs are required before strong guideline adoption can be made worldwide.